All right, so how do we maintain autonomy for the person who is having challenges to their autonomy? You know, suppose a person, their relative is incapacitated, no advance directives, no durable power of attorney for health care, which, as we noticed, is most of the people. Which question would be better to help your patient maintain autonomy? Question A, what do you want us to do for your family member? Question B, what do you think your family member would want done if they could speak for themselves? Obviously, the second question helps maintain autonomy. And in asking it that way, you are reminding them to take that person's beliefs, religions, morals, standards into consideration. They're not obligated to do that, but hopefully it'll make them think about it. Now, if there's no information about what the person wants, remember we talked about advance directives, written documentation, verbal documentation, and relational experience. If none of those are around, surrogates are obligated to do what is in the patient's best interest. For physiological criteria for relief of suffering, that's the most basis. Restoration of functioning is a higher level of expectation. Surrogates are held to a higher standard. They are not allowed to make unusual, eccentric, or poorly reasoned choices without strong evidence that the choice reflects the patient's wish. It could be, this is extreme, but let's say the person says, you know what, I can't even think of anything right now. Sorry, I'm just drawing a blank on eccentric or poorly reasoned choices, but you'd probably identify it as if you heard it. Now, what about, I'm sorry, I'm lost here for a second. DNR orders. An advance directive can say no DNR. But what if there isn't, what if there is no DNR order, but there's an advance directive? Person can go in, DNR always has that bracelet, right? So the person does not have a DNR bracelet, but their advance directive says no CPR, no chest compressions, no ventilators. That advance directive would overrule the DNR order, wouldn't it? So think about that. Now, CPR and DNR. In-hospital success rates for CPR vary widely from the hospital, from anywhere from 19 to 57% of success. But only 4 to 24% of patients who receive CPR are discharged alive. So at best, 1/4 of the people who get CPR are discharged alive. 1 in 4. And in some places, as few as 4 in 100. I don't want to go to that hospital, just so you know. But only 13% of people who are hospitalized have resuscitation. Okay, we talked about that earlier. 1 in 10 patients in the ICU receive CPR at the time of death. Patients who have CPR are more likely getting it because they have a cardiac problem. So, a heart attack. That will usually trigger CPR, but a person who has had chronic cancer probably won't. Because think about it. CPR, cardiopulmonary resuscitation, or cerebral pulmonary resuscitation is designed to get the heart going, right? Because if the heart stopped because if the heart stopped because of a heart issue, restarting the heart may correct the underlying problem. But if the heart stops because of another chronic disease, cancer, diabetes, stroke, then restarting the heart may not have any benefit at all. That makes sense? It probably should. You guys are all smart students. Does CPR require a consent? No. Can a patient refuse CPR? Yes. Is it a treatment or a right? Ooh. Do patients have a right to CPR? Or is it just a simple treatment? What do you think? I think if the person is not a DNR and they have not said no CPR, then I think CPR should be tried. It's a right. My opinion. Can a patient refuse CPR? Well, if they put in their advance directive, no CPR, they're refusing CPR. Patients can refuse treatments, correct? Sure. They can refuse any treatment. So they can refuse CPR. Now, can they refuse CPR while CPR is being done? If you're doing chest compression and suddenly the person goes, hey, stop, your chest compressions have succeeded. Stop. If the person has said no CPR in an advance directive and you do CPR, or if they're a DNR, they have a DNR bracelet on, and you do CPR and you bring them back, what law have you broken? That's assault and battery. It really could be charged. You could be charged with assault and battery. Now, DNR is one of those anticipated treatment or anticipated refusing treatments. There should always be informed consent when there's DNR status. The doctor needs to explain to the patient what will happen if their heart stops and we don't do CPR. So whenever there's DNR, that should always be at the end of thorough education, both for the patient and the greater family. Let's talk some ethical issues here. Looking back at treatment versus right. How would you feel about CPR in a person where it's futile? Again, looking at that terminal cancer patient or the person who's in persistent vegetative state. Would you participate in CPR in that situation? Do family members have the right to demand CPR even if the medical opinion says it's not going to help? They do. They do. Many institutions are switching from DNR, do not resuscitate, to DNAR, do not attempt resuscitation. That kind of is more encompassing. I have seen DNR orders that were messy. I have seen patients say, you can do chest compressions, but don't intubate me. Or you can give me medicine, but don't do chest compressions. Or you can do chest compressions, but don't use electricity. They're really bizarre. And in all of those situations, it really means more education is needed. Because if any of you have ever participated in a code, you know that if you don't do all of those, nothing's going to work. Yes, you can probably get by without intubating, but only for a while. There are a lot of times when CPR, chest compressions bring a heartbeat back, but they need to be ventilated to keep them alive. You're not going to stand there for hours on end begging the person. So when people start making complicated DNR requests, that's a sign that more education is necessary. And there's two types of futility here. We talked about that earlier when I said, would you participate in CPR in a futile situation? Two types of CPR: qualitative futility and quantitative futility. So they make a difference. Qualitative futility says the person will not regain neurological function, will not have meaningful consciousness. It's a quality of life. Quantitative futility is a low probability of restoring organ function. So one is living and one is life. We go back to that early on definition. Quantitative futility means unlikely giving life back. Qualitative futility means unlikely restoring living, quality of living, of participatory living. Quantitative futility quantitative futility, when there's less than a 1% chance of producing a physiological effect, such as restoring cardiac function, when it's when you're at that level, then you probably should not start. What about CPR for sepsis, or bad stroke, cancer, pneumonia, GI bleeding, heart disease, severe heart disease, renal failure? Studies have shown that in any one of those conditions, so sepsis, stroke, cancer, pneumonia, GI bleed, heart disease, or renal failure, they have at best a 6% survival to discharge if CPR is started. 6%. And of those 6%, 78% will require permanent hemodynamic monitoring, ventilator, or dialysis. So in other words, external pacemaker and a ventilator and or dialysis. So at most, 6% will survive CPR, and then 78% of those will require a machine to stay alive. Was that in the patient's best interest? I don't think so, personally. But that's my personal opinion. If a person has sepsis to the point where their heart stops, my opinion, it stopped for a reason. Now, that's my opinion. We can all have different opinions. And that goes back to the deontological and teleological situations. Deontological meaning you have a set decision path. All life is sacred, all life is worth trying to save, or teleological, where the end justifies the means. Or if the end doesn't justify the means, you don't do it. Like, you don't do CPR if you have a 6% chance of maybe bringing them back to life, and of that 6%, 78% will be on a machine for the rest of their life. So, deontological, teleological. Told you those words are going to keep coming back. There are portable DNR orders. Now, a portable DNR, see, DNR is in the hospital. It's a hospital order. When they go home, those orders are no longer in effect. But some patients do qualify for permanent DNR orders, meaning DNR no matter where they are. In Wisconsin, the patient must be 18, must have a terminal medical condition, a condition that says CPR is unlikely to be successful, and or a condition that CPR would do more harm than good, like severe osteoporosis. Because now you know in CPR you're going to break ribs. It's not an if, it's a will. But if a person has really severe osteoporosis, you could crush things. That's odd. The lights just went out. Hi, I'm back. Okay. So portable DNR orders do exist. Now, you have to have the healthcare provider's signature and the patient. Everybody receives a copy of it. And most states do allow one exception. In a situation where emergency medical services are called, most states allow family members to overrule that DNR and ask EMS to provide CPR. Again, this is a situation where family members need to be on the same page and kind of be in agreement. It's a very stressful situation when a person's heart stops. And sometimes stressful situations create bad decisions. There should be some systems put into place. It'd be nice if everybody understood CPR or DNR means DNR, that all family members, caregivers, potential caregivers are made aware of it. Hospitals should allow patients and their surrogates to refuse, even in the absence of a written order from a doctor. Now, that's not always the case, but I have seen in the ER where family members are the ones that tell the doctor no CPR. I saw that once where the husband and wife were there, the wife's heart stopped, the husband looked at the doctor and said, "Don't do anything." So the doctor wrote DNR. But that was not written until the husband said it. It's ideally multiple witnesses are there and disinterested witnesses. So those are some things to keep in mind when DNR is happening. Now, withholding or withdrawing treatment, those are very different. Withholding treatment means you never start. And that's sometimes easier than withdrawing. Withdrawing means you're taking it away. So you never start CPR. That's one thing. Or stop CPR because it's not working. That's different. You're not going to put a feeding tube in at all versus they have a feeding tube, but now you're going to stop feeding them. Very different feels, very different emotions involved. Stopping CPR is difficult in most situations, especially if the person is young. I was present at the CPR of a 6-month-old. And they did CPR for a long time, and finally the father said, "Stop." That was hard. The child had a congenital heart defect, so it was not an unexpected occurrence. It would probably have been easier to never start, but we started, and eventually we had to stop. Comfort treatments should be continued, even if curative treatments are being stopped. But what qualifies as a comfort therapy? Food, water? Bed baths? Yeah. That should be continued. But what if the person refuses? Then they refuse. What if they refuse a bed bath and they develop bed sores? They should be taught, they should be educated. If they refuse bed baths, if they refuse turning, that bed sores are not likely. They're almost guaranteed. It's an educational part. Now, let's go back to autonomy versus beneficence, and we're going to look at hydration and food. Food and water. Food and water is pretty basic, right? When we go to people's homes, they offer us something to eat or drink. When somebody comes to our house, we provide food and drink. It is more than just food and hydration. It's more than just nutrition. It is a way of treating other people, showing courtesy and respect, and giving and sharing. So think of that when we say, would you withdraw a feeding tube? Would you stop using a feeding tube? Would you stop giving IV hydration? IV hydration will keep a person alive for a long time, even if they do not want any other life-giving treatments. What about food? Food isn't medicine. The way it's provided might be medical through a feeding tube, but it's not really medicine. So should we withhold food? A lot of times, as people get near death, they don't want to eat anymore. That's okay. If they choose not to eat, they're choosing not to eat. But if they have a feeding tube in, we can force feed them. Is that right? Are they hungry or not? If they're not hungry anymore, even with a feeding tube, should we feed them? Probably not. If they want to eat, let them eat. Artificial hydration is considered a medical therapy that can ethically be withdrawn. It's medical treatment. Now, we're not talking about the ability to eat or drink, but we're talking about IV hydration, TPN, feeding tubes. If a person still wants to eat and drink, if they're able to eat and swallow and drink, then they get to do it. You can't hold food away from them. But you can decide to stop artificial feeding and artificial hydration if the patient wants that, or if the surrogate wants that. There's a lot of ifs and but and only, there's a lot of, remember I said ethics is a very gray topic. Many people lose the sense of hunger and thirst as death nears. They just don't feel hungry. They don't feel thirsty. They stop eating and drinking, and that's a sign of oncoming death. But it can last a long time. A person can stop eating and stop meaningfully drinking for days, weeks, potentially months. Usually death occurs in 1 to 3 weeks, but not always. It's very difficult to watch a person stop eating and stop drinking and yet stay alive. But that is what people choose, and that's okay. Don't Don't make them prolong their life if they don't want that. Tube feedings can be used if they have difficulty swallowing. If they want to eat but can't, tube feeding is appropriate yet. But if the person has said, I don't want to eat, I don't want the tube feeding, and I want the tube taken out, then it should be taken out. It's their wishes. Now, what if the person has dementia? Then we have to decide for them. What have they said in the past? Remember, we go through that decision tree. What's written down? What have they said? And what have they done in the past? That's how we decide. All right, I'm going to stop here for this is part C. I'm going to stop. We'll come back to part D, and I think that'll be the last part.